So what we're going to talk about today is what's called the SubV knee or vastus knee replacement. And it's a complete muscle and tendon-sparing approach knee replacement that I think has some advantages for people in the recovery process, a little quicker recovery, and some advantages for patients. And we'll go over that today. Okay, just a little bit about myself. So I've been here at Ortho Virginia since 2009. Doesn't seem like that long, but it's been many years now. I specialize pretty much just in hip and knee replacement surgery. That's all my practice is now, is hip and knee replacement. I did a fellowship training, which is training after residency in joint replacement surgery. And at this point, I do a lot of hip and knee replacement surgery. So I do almost 1,000 hip and knee replacements a year. So I do far and away the most in Central Virginia. And that's really what I've tried to focus my practice on and develop a real specialty and expertise in. I have some leadership positions in Ortho Virginia. I'm on the board of directors for what we call the Central Region. Ortho Virginia is a statewide organization with several regions. The Central Region is the Richmond area, which you think of as Ortho Virginia, and is the largest region. And I'm on the board of directors there, also the state board of directors, and I'm the president of the Central Region. So I'm the physician leader of the Ortho Virginia offices here throughout Metro Richmond. So our objectives for the talk tonight is to educate you about approaches to knee replacement. But to do that, we have to back up and educate a little bit about several background topics that we have to understand. We'll talk about knee anatomy. We'll talk about some of the basics of knee replacement surgery. When someone says they're having a knee replacement, what exactly are they talking about? We'll talk about some of the differing techniques. And then we'll talk about sort of minimally invasive muscle and tendon-sparing SubV or subvastus knee replacement. What are some of the potential advantages? And what are some of the recovery expectations you can have, understanding that in any surgery, recovery is patient-specific. So we're going to talk about the normal and averages that we see in practice. Okay, so let's back up and just talk a little bit about knee replacement surgery. So where did it start? We think about hip and knee replacement having been around forever, but it really hasn't. First knee replacement was done in 1968 by a Canadian, Dr. Frank Gunston, with a very rudimentary knee prosthesis. It almost looks like two runners on skis here. But this is the very beginning of knee replacement surgery. The first modern knee replacement that you would think of as a knee replacement that looks sort of like what we have now was actually in 1974, so not that long ago. It was done at the Hospital of Special Surgery, and these are some of the early components, the Insull-Bernstein knee, the total condylar knee that were out in the 70s. So let's talk a little bit about knee anatomy. When we say the knee, what are we talking about? Okay? So the knee is made up of three major articulations, three bones that are coming together to make up the knee. We have the femoral bone, which is your thigh bone, and as it comes down towards your knee, it flares out to what we call the femoral condyles, which are covered in cartilage. There is the tibia, which is your shin bone. As it comes up towards the knee, it has a flat aspect to the top called the tibial plateau, which is also covered in cartilage. And then there's the patella, what is commonly known as the kneecap. And that glides in a groove on the femur called the trochlear groove, and both the groove and the backside of the patella are also covered in thick, cushioning cartilage. Okay? So when we look at the knee here, we have several ligaments. We have the lateral collateral ligament, the medial collateral ligament that give the knee stability. We have the meniscus on the inside and outside. So there's cartilage on the ends of the bones, and there's also this thick gasket of what we call fiber cartilage. It's a very thick, tough type of cartilage that's called your meniscus. So a lot of people have heard of meniscal tears. These are the tears of these two structures on the inside and outside of your knee. So what is knee arthritis? That's a good question. Or what is arthritis in general? Arthritis is more of a catch-all category that people use to describe pain in joints. And that's really what it means. So arthro is the Greek word for joint, and itis is the Greek word for inflammation. So it means joint inflammation. But when we talk about arthritis, typically we're talking about what's called osteoarthritis. And that is a wear and tear type of arthritis that can be associated with several things, including past trauma. It can be associated with activities. But the main association that you see is with age. So we see that arthritis becomes more prevalent as we move through life. You can have young people with osteoarthritis, but it's much more common, excuse me, for someone who's 75 to have arthritis of the hip or the knee than someone who's 25. So when we talk about osteoarthritis, what is going on at the joint level? Because sometimes the idea is the arthritis is it like cancer? Is it something you can go in and take out? Is it a structure? And it's more of a process. So what you can see here in this knee, this is a normal knee, is you have this smooth, glistening white cartilage on the end of the femur. And so if you were to take, say, an average 20-year-old person and look in their knee, you would see perfectly smooth cartilage that's very thick and cushioned on the ends of the bones. When you have a knee that has arthritis, or we'll call it osteoarthritis, what you start to see is breakdown of that cartilage. And so you get loss of the cushioning cartilage, and you start to get inflammation in the underlying bone. That's the process. Now, why exactly that happens in some people and not others, we don't know. Basically, you can think about arthritis of the hip or knee as aging of the hip or knee. And just like we all age in different ways, some people show aging in different ways, joints show aging in different ways. So if we look at an x-ray, when we say, we talk about arthritis, a lot of times you'll hear, is my knee or my hip bone on bone, okay? So what we're doing, let's look at a healthy knee right here. I'll step aside so you guys can see. I don't want to block your view. You can see there's the femur bone here, the tibial bone here, and there's a seeming space in between, okay? That's not actually space. That is filled with something. What it's filled with is this cartilage, but the cartilage is not calcified, so it doesn't show up on an x-ray. So what you see is a space that's relatively symmetric and thick between the bones. Now, when we go to an arthritic knee where we've lost the cartilage, what you'll see is on the outside of the knee, you see good space. On the inside of the knee, we see loss of that space and essentially bone-to-bone contact because the cartilage is now missing. So this is what we would say, this knee has bone-on-bone arthritis or end-stage arthritis. So let's talk a little bit about knee replacement. When we say we're doing a knee replacement, what are we talking about? Some people think we're going to take the whole knee out and grab one off the shelf and put it in, like the whole structure. And what we're actually doing with a knee replacement is a resurfacing procedure. So if you look here, so we'll say this is the arthritic knee. We have lots of holes in the cartilage, loss of the cartilage, patients having a lot of pain. A knee replacement doesn't involve removing all of this. It just involves removing enough bone on the ends of each side to put in basically a cap on the femur, a cap on the tibia, and then we have a plastic spacer in between that functions essentially like the new cartilage that keeps these two structures apart. So we're resurfacing, you can see here as well, arthritic knee, total knee. So there's not that much bone that's taken. We're probably taking, in most cases, between 7 to 10 millimeters of bone off the surface, but we're reshaping the end of the femur to accept this prosthesis. Same thing on the tibia, and taking enough bone to allow us to put a plastic spacer in between to allow the knee to glide and function in a biomechanical fashion. So if we look at knee replacement implants, this is basically in office, I'll show patients sometimes the different implants. This is a femoral implant, okay? So it looks like that. Basically, it mimics the shape of a normal femur. And this would be the tibial implant. It goes down into the bone to anchor, has a flat surface here, and you have a plastic spacer that locks into the tibial component. And then when you get an x-ray, this is what it looks like, right? Because we have the femoral component that's capping the femur, the tibial component here that's anchored down in the bone, and then the space that we see there is now not cartilage, now that's the plastic that doesn't show up on x-ray. So we talked about knee anatomy, this being knee anatomy. This really isn't knee anatomy, right? So those bones don't just exist there. Those bones are covered with all other types of structures. So, oops, let me go back. So when we actually look at a real knee, it looks more like this. If you were to take the skin off of the knee, this is a sort of schematic of how the knee would look. So there's the kneecap, the patella. You can't really see the femur or the tibia because they're covered with all of these structures, and these structures are very important. So this muscle up here, which really forms the bulk of our picture, is called your quadriceps muscle, right? Quadra, 4 heads. It has 4 different heads that come down, and they coalesce on one tendon called the quadriceps tendon that attaches on the patella, that then forms the patellar tendon and attaches down on the bump in the front of your tibia called your tibial tubercle or tibial tuberosity, okay? So when you contract, when you fire your quadriceps, when you tighten your leg, it pulls your leg straight. And that's the main motor of your leg. That's what prevents your knee from buckling. That's what allows you to climb stairs. In the back of your knee, there's the hamstrings that do the opposite, right? When you flex those, it bends your knee. But this quadricep is the largest muscle in your thigh, and that's the main motor of your thigh. So let's talk about some of the ways. So in order to do a knee replacement, we have to get into the knee first of all. That's the thing. And so what we're going to talk about now is different ways of getting into the knee. The subvastus knee or SubV knee has nothing to do with the implants we're putting in. The implants I showed you before, whether you did a traditional approach or a SubV approach, you're going to use the same implants. What we're talking about is how we handle the soft tissues to get into the knee to do the surgery. So the most traditional method for performing knee replacement is what's called a medial parapatellar arthrotomy. Okay, I'm going to grab over here my model. And so if you look here on this model, or you can use the picture, we have the quadriceps tendon. And imagine there's a large amount of muscle here that's inserting onto this tendon. You have your patella and you have your patellar tendon. So in a medial parapatellar arthrotomy, what we're doing is we're making an incision in the quadriceps tendon. So we're cutting the tendon, coming around the patella, opening it, and basically booking open the quadriceps. So the patella is going to go this way. Sorry, I need one more hand. And the rest of the muscle and tendon is going to go this way. So essentially, we're going to open the quadriceps in half. Okay? This is the traditional way, and still probably 90% of knee replacements in the country are done in this fashion. You can have a good result with this. And the truth is that at about a year out, it probably doesn't make a lot of difference whether you do a subvastus technique or a medial parapatellar technique as far as long-term recovery. What we're talking about is really the first 3 to 6 months, trying to get people back as quickly as they can. So this is a more traditional knee replacement approach. Make an incision. Oops, let's go back. Make an incision here along the tendon. Open the tendon. Move the muscle, basically split the muscle in half, and get into the knee in this manner. Now, the subvastus or SubV approach is a more medially based incision. So the incision is more off to the side of the knee, not directly on the side, but more towards the side. That's how I like to do it. It's completely muscle and tendon sparing because the deep incision goes under or sub the vastus medialis muscle. So in this case, instead of cutting through the tendon and muscle here and coming around, I would go and find the edge of the muscle, free it up from basically the underlying soft tissue, and then allow all of this to reflect over to extend the knee, keeping all of this intact versus making the cut in the tendon and muscle. Okay? So what are some of the potential advantages of subvastus or SubV knee? One potential advantage, I think, for a lot of patients is less pain. This doesn't mean the surgery is pain-free. Okay? So we're talking about trying to make it better, but not pain-free. There's no incision through the quadriceps tendon, and therefore when you're bending and extending your knee after surgery, we're not pulling through that repair. So we have an intact tendon and muscle structure that we're using right away. Another potential advantage I think that makes a lot of sense is more strength, okay? Because we're not opening the tendon and muscle, we're leaving everything intact. I think I've seen in patients, and there's some good data in multiple peer-reviewed papers, that patients tend to have a little bit more quad control, a little bit more strength early on in the recovery process. This allows things like improved stair climbing, better ambulation, and better quad control, less knee buckling, okay? Another potential advantage is improvement in range of motion. Again, when you're bending the knee, we're not pulling through that repair, we're not pulling through that area where the tendon and muscle have been split, and so the idea is that patients can potentially improve their range of motion more quickly. And then there's patellar stability. So after a knee replacement, we want the kneecap to sit pretty much in the middle of the prosthesis here. We don't want this situation. And what can happen in rare situations is that when you make the incision through the tendon and the muscle, if that area were to dehiss or come apart, the patella can become unstable. And I think the subvastus approach lessens that risk significantly because you haven't opened the tendon and muscle and you've kept everything intact. The final advantage that sort of sums these up is just quicker recovery. again, I want to make the point and be really honest with everyone about this. I don't think at a year out it makes a lot of difference. But a lot of patients do care about the first 3 to 6 months. They want to get back to things more quickly. They would like to potentially have less pain. They would like to potentially advance more quickly with physical therapy. And so what we're trying to do is get people back to things like work, hobbies, activities, family, trips, vacations, all those things they want to do more quickly or as quickly as we can. Again, just having this doesn't mean it's a walk in the park. Knee replacement is challenging. I think anyone who's had a knee replacement would tell you it's a challenging recovery, but we're trying to make it better. So a common question that I get is, why don't all surgeons perform the SubV knee? And there's really multiple reasons. First of all, there are a lot of my partners here in Richmond that do perform subvastus knee replacement now and have started doing it in the last year or two. So we do have several surgeons other than myself that are doing this. But the exposure is more technically demanding. It's a little harder. It's a little easier just to make an incision down the front and just to open the tendon and muscle. It's a little quicker doing the surgery that way, I think. So this surgery, it's doing the SubV technique, a little more technically demanding, takes a little more time during surgery. A lot of surgeons just are not that familiar with the technique. People tend to do what they're comfortable with, and that's okay. And it's very similar reasons regarding, like with hip replacement, that I feel like doing it through the front, a muscle-sparing anterior approach is much better. However, there are still a lot of folks that do it through the back, and that's just what they're comfortable with, and they stick with that, and you can still get reasonable results that way. So another question that I get is, who is a candidate? So like if you're having a knee replacement, am I a candidate to have a SubV knee? And I would say for most people, the answer is yes, okay? But there are some reasons we want to think about a more traditional approach. One could be having had past surgery or extreme stiffness. So if you've had significant past surgery that's called scar in the knee, that quadriceps muscle we talked about, it doesn't want to slide, okay? There's scar, it's more bound down. And in that case, we risk tearing the muscle or causing more damage trying to slide things out of the way versus just doing a more traditional technique. So that's one reason that SubV knee might not be the best situation. If you've had past surgery and there's hardware that we have to get to remove, plates, screws, things like that, sometimes the more traditional approach could be a better option. Revision surgery, as we talked about, and then patients with significantly elevated BMI, where the weight's up significantly, if there's a lot of tissue around the knee. If there gets to be too much tissue, it's hard to get it all to retract and slide out of the way. So those are all considerations. And I usually have a discussion with patients. I tell them, like, you're definitely a candidate, you're definitely not a candidate, or we'd have to see how the knee, basically how much mobility you have, especially when we get on the operating room table. A lot of times people will be stiff in the office because of pain, and then when they get on the table and they're under anesthesia, the knee moves fine, and I know that it's fine to proceed with the SubV approach. So what are some of our goals after doing a SubV knee? We want to have reasonable pain control, not zero pain, but reasonable pain control after surgery. We want the patient our goal is for the patient to be able to perform an independent straight leg raise after surgery in the recovery area. Not everyone can do this, but I would say a lot of patients, probably most with the SubV knee can. We want the patient to be able to ambulate with a walker, climb stairs immediately post-op. You'll see some videos later about patients we've had in our surgery center up here where they're doing that. Most of our surgery we're doing now, both hip and knee replacement, is outpatient. So people are having surgery, coming to recovery, waking up, doing therapy, and then going home usually within a couple hours. And that's a goal of ours for most patients. Some patients with more challenging medical conditions, we still do it at the hospital and keep those patients overnight. We'd like to see the patient off the walker within several days. And again, that's patient specific. Some people are off the walker almost really very quickly after surgery, and some people it takes a little longer, and that's okay. We're hoping to see more rapid progress with physical therapy and return to work and other activities they want to more quickly than with a traditional knee replacement. But again, just being honest, outcomes vary patient to patient, so it's dependent on the patient as well. So what we're going to do is we're going to try to get the video, Aaron, if we can get the video to go. We have about I think it's good to hear from some of our patients and see what it's like after surgery. So this is about 8 or 9 minutes of several different patients. All these patients have consented to using their video in patient education. And so you'll get to see just a little bit about their experiences after surgery. We say? Yeah. Let's do that.
is about an hour out from the invasive left SubV knee replacement using the subvastus approach. And how are you feeling, Ms. Lavasic, with regard to pain?
I'm feeling fine on a scale of 1 to 10, maybe a 2.
Okay. Are you able to lift the leg straight up? Good. So able to do a straight leg raise. Excellent. Excellent. Well, it looks like you're doing great. We really appreciate it. And we'll try to get some videos of you up and walking upstairs a little bit.
Thank you.
I moved over so I'd be more facing the camera. So.
Yeah, that's perfect.
Yeah, it's good. Okay, cool.
So I'm here today with Mr. Craig. He's about an hour out from the right SubV tendon knee replacement. So just how are you feeling?
I feel good, just a little uncomfortable.
Gotcha. Is your pain pretty well controlled?
Yeah.
Okay. And let's see if you can lift the leg straight up. Okay. No problems with that? That's great. So we'll see how you feel when we get you up walking in just a few minutes.
He is one of our more joyful patients.
Walking is great. You're about 45 minutes out of surgery. We just did a subvastus left total knee. How are we feeling? How is the pain? Okay. Are you able to lift that leg straight up? Perfect.
I have Mr. Fisher here, who is 2 weeks post-op from his left total knee replacement through the subvastus approach, and he is doing extremely well. Mr. Fisher, how would you say you're doing at your 2-week mark? Yeah, and that's great. And you had your last one done a couple months ago, correct? And how's physical therapy going so far? Good. And how would you say your pain is at the 2-week mark?
Probably
Okay, great.
more irritation.
That is great to hear. Well, let me have you lay back if you can, and you can just show me how your range of motion is doing so far. So this is at 2 weeks, and he can get his leg almost completely straight, and then he's able to bend it up quite a bit at this point. He's also able to do a straight leg raise at this point. You can just show us how you're able to do that. So go ahead and bend straight it down. Perfect. Very good. All right, and you can go ahead and sit back up for me. And he is already at the point that he's able to walk with just a cane. And you said you were able to go to a cane how quickly after surgery? Okay, that is great. Overall, pleased with your experience at the Outpatient Surgery Center, and that is great. All right, well, thank you very much.
Mr. Andrews. He's about 8 weeks out from a right SubV knee replacement upstairs at our Westchester Outpatient Surgery Center. How are you doing?
I'm doing great.
Yeah. How is your pain now in the knee?
The pain now is probably, I would say, between a 1 and 2 on a scale of 1 to 10. I mean, it's almost just like nothing.
Good. So are you back to doing most of your activities you want to do?
Yes, sir. I'm doing my prayers, yard work, walking.
Okay. How quickly did you get back to activities after your knee replacement?
I would say probably, 4 to 5 weeks afterwards.
You were back doing most of the things you wanted to do?
Yes.
Okay, great. Would you mind going back and just showing other patients how your range of motion is going? If you can straighten the leg all the way out?
I can straighten all the way up like so.
Excellent. And how about your bend up?
Bend up. I feel like I'm bending all the way back as far as I used to bend.
Good, good, good. You can sit up for us. All right. How was your experience at the surgery center?
Oh, it was great. I great job from 1 to 10. I give y'all a 10. Everybody was so great here. I would definitely do it again.
Good. Well, I'm glad you're doing well, and thanks for sharing this with patients because it's great for them to see how another patient's doing. Thank you.
That's good. It always helps out.
Today I'm with Mr. Belcher. He is one of our post-op patients. He just had a SubV knee done about 2 weeks ago at our Boulders Outpatient Surgery Center. Mr. Belcher, how are you doing today?
I'm doing great.
On a scale of 0 to 10, what would you rate your pain?
1 today.
That's great. How have the last 2 weeks been? How have you felt?
This has been a great experience, very low pain, very just low discomfort, and the whole process and procedure has just been amazing.
That's great to hear. How was your experience at the Boulders Outpatient Center?
Man, they were top notch, 100%. Everything that everybody I dealt with was hands-on, professional, kind, caring. I mean, it was just a great experience all the way around.
That is so good to hear. Well, if I could, I'm going to have you lay down for me and then just show me how you're doing with your movement today. So if you could just do a straight leg raise, that is great. And then just show me how you are bending your knee and go as far as you can. Oh, that is great. All right. And you can go ahead and sit back up for me. And then what we're going to do now is I'm going to have you just come out in the hall with me and we're going to watch you walk for a second.
Sounds great.
If you just want to go down that way for me and then you can turn around and walk towards me. Oh, that looks good. All right. You can go ahead and turn around now and come back towards me.
It's up to 2 weeks.
That is so great. Awesome.
All right, we're here with Mr. Urena, who is about 2 months out from a SubV knee on the left side. How are you doing with your pain with walking and stuff now?
So I can walk 4 times a day. I don't have any pain. I have a little bit of the tight bend around the knee, but we talked about it and supposed to last a few months. Overall, I really never had any pain. I think one of the critical steps was to actually know your PT. Go to PT, try to push as much as you can.
And you worked hard with physical therapy, obviously, yeah.
I think that's what you do.
Awesome. Would you mind just laying back and showing us how your range of motion is? You can stretch all the way out the stage. Okay, so full extension, and how far can you bend up? Very good. Well, that was great. You can sit back up, Mr. Urena. Thank you. Well, thank you very much. I'm glad you're doing well. And I think you'll continue to improve, and you're off to a great start. So thanks for sharing this with other patients.
Well, thanks to you and thanks to the staff over there. You guys have been great.
You're very welcome. Okay, we're here with Jo. She's about an hour out from a SubV left to the knee replacement. So how are you feeling?
It is so worth it. I'm great.
Well, I'm glad you're feeling well. Can you lift the legs straight up? Awesome. You're doing really well. Jo again, she's an hour out from her SubV. How are you doing?
I feel great.
How was the walking and stairs and everything?
Almost less pain than what I was walking every day.
Oh, thanks, Todd. Appreciate it. All right. So while I'm thinking about it, they gave you guys these handouts, and so we made these for patients. One of the things I've been meaning to do over the last couple of years is provide more patient education material. And so I made a resolution to myself about 1.5 years, and it's taken a little while, but I think we've gotten there. We have several different platforms, so YouTube, Facebook, Instagram, TikTok. And so we've created a lot of content. We're going to create a lot more, not only with patients, so all of these videos are there, more patients. We want to go more in depth with patients, ask them about their recovery and what to expect. And so other patients can go and listen to them and understand, like, how quickly can you drive? How much pain medicine did we need after surgery? All of those things. And then there's several videos on there. We're going to create more where I'm giving talks about things that are specific to hip and knee replacement, questions that patients may have. And so if you would like to, you're welcome to check these out. And we're going to keep building these sites, and hopefully it can be a source of information for patients. Maybe, Aaron, if you turn it down. turn it down a little bit more. I know we turned it up for the thing. But it can be a source for information for patients, not only here in Richmond, but anywhere who want to learn more about hip and knee replacement and try to answer some of those questions when they're making these decisions. Okay, so how common is the SubV knee? It is performed throughout the country. In Richmond, the exact prevalence is unclear. I'd say maybe 10, 15% of knee replacements in Richmond are done through a SubV approach. Now the majority are still done through a traditional approach. We talked, you saw in the videos, a lot about outpatient surgery. This has definitely grown in prevalence over the last 5 years. I went from doing no outpatient joint replacements in 2021 to doing the vast majority of my surgery outpatient now. So it's become very popular. I personally perform about 600 or more this year outpatient total joint replacements where people have surgery, then they recover in the recovery area, and usually home within a couple hours. I think for patients, this has been super beneficial. Most people really enjoy recovering at home versus being in the hospital. I think our anesthesia teams we have at the outpatient center, because we know patients are going home, our anesthesia teams have gotten very specialized in doing preoperative pain blocks, managing post-op nausea, managing all these things that people, being lightheaded, fluids, all of that. They've done a great job with that. And so our patients are now able to have surgery and really be home within a couple hours. So for some patients, if they have significant medical issues, like for instance, we're working through this, but patients with cardiac pacemakers still have to go to the hospital. Patients that have significant cardiopulmonary disease or maybe a little bit older, still best treated at the hospital, but the majority of our patients are now done either at our Westchester Center right upstairs here, which is an amazing facility, or at our Boulder Center, which is over near Chippenham Hospital. So a question that people in here could think about, or really I want patients overall to think about, is how do you choose your surgeon? And I'm telling you this not because I'm saying that you have to choose me. I have a lot of great partners, but I think this is good information to think about as a patient. So when we think about having surgery, I'm going to use the analogy of building a house. So I've been through it once. We're getting ready to build another house now. And as you know, it can be a challenging experience. But if you're naive to building a house, you may think, well, just get a builder, right? Just go and look online, builders in Richmond. That guy's available. I'll choose that person, thinking that I have plans and that things are going to always turn out the same way. And that's just not true for building a house. I think anyone who's built a house or had construction projects knows that. The same is true with surgery, okay? You can have good outcomes and you can have not good outcomes. And so when you're making the choice about having surgery and choosing a surgeon, I think there's a certain number of principles you could guide yourself with that will lead you to a better spot versus just picking someone out of thin air. And there are several papers, I put this up there, this is a lead paper in one of our journals, that looks at actual evidence, statistical evidence about outcomes of joint replacement. And there's a few things that they came up with. And I think if you look at this, it will make sense to you, okay? So the first is experience. How often has this person been doing it? How long has this person been doing it? Okay? The same with any industry that any of you may be in, right? The more experience you have, the better you're going to be. And there is gradations of experience, and there are gradations in outcomes for patients. Another thing is volume. How much do you do of this? It sort of is very similar to the experience part, right? The more volume you do, studies have shown, generally, the better patient outcomes are going to be. Same for surgical facilities. If you go to a surgical facility that does 3 knee replacements a month versus a surgical facility where the staff is accustomed to doing knee replacement and they're doing 200 knee replacements a month, you're going to generally have better outcomes at the high volume facility just because the staff are more facile with the procedure. They have protocols down better. Same thing with surgeon experience. Another thing you could look for is training. Did this person do additional training in joint replacement? The answer for me and for a lot of my partners is yes. We've done additional fellowship training in joint replacement where we learn more about the higher level techniques, how to deal with more difficult cases, just getting that experience before going into practice, okay? Another way is ask around. Ask your friends. Ask, people that you may be in community with through clubs, churches, whatever relationships you have, how has their experience been? How did they interact with this surgeon? What kind of response or overall outcomes did they have, and were they pleased? Mike is dead now. So we were really loud, and now I'll just try to speak really loudly. Hold on. I think we're coming back online. Backup mic coming. Yeah. Thank you, Aaron. Okay, we're back on now. Sorry.
About that. That's okay.
And the last thing is the facility. As I was saying, that's related to volume, right? So if you go to a hospital facility or surgery center facility where this is what they do, joint replacement, they're doing 500, 1,000 joint replacements a year, you're going to generally have, statistically, probably a better chance for success than in a facility that's doing just one a month, okay? It just comes down to repetition and practice. So those are things that you could use, or if someone asks you about how to choose, maybe that person's in, South Carolina, and they're looking how to choose. This is important information for anyone to have, not just in Richmond, but all over, as far as how you choose. And choosing actually does matter. So why is surgeon choice important? And some people say, well, I'm just having a knee replacement. What could go wrong? Well, the answer is a lot. A lot of things can go wrong. And so when you have someone who has not had a good outcome, sometimes it just doesn't go well. I would love to tell you that every patient, operating on 1,000 people a year almost, that every patient is 100% happy and everybody would have been up there in those videos. That would not be true. Now, I want to tell you the truth, which is that we're operating on people, and there's always a variation in outcomes. But making good choices as far as who's doing your surgery gives you a much better chance of landing at a good outcome. And so I'll give you an example. This is a patient. We'll just say initials DG, 59-year-old female that I saw recently. Had x-rays. These were original x-rays when I first saw her back in 2021. She had a knee replacement with another surgeon, and she was unhappy. Her knee was stiff. It wouldn't move, and she had pain. So what you can see here, you probably don't look at x-rays as often as I do, obviously, but the component is failing. So it's sliding down in the bone on the inside part, and the balance of the knee just wasn't great, okay? So in addition to that, she had arthritis in her other knee as well. So she has a problem with the knee that she had replaced. She has a problem with the other knee. And so we went forward, and the first thing we said was, let's get one good knee. And we fixed the left knee. We did a subvastus approach. She had outpatient surgery. She did great. It was a much better experience. She was very happy. But we still had this knee here. And so we actually said, well, we think we could do this outpatient as well. So I went in and was able to retain her femoral component and just remove the tibial component, fill some of this bone void with cement, and get a new implant in, and now she's doing great. Now, so that's an example of what can go wrong with surgery. Fortunately for her, I think everything turned out well, and she's doing great now. Another question I get is, what's the difference in a SubV knee versus what some people call a Jiffy knee? And I get this question a lot, so I just bring it up. The bottom line is, I've been doing orthopedics now. I've been in practice for 18 years, and I was in training for 6 years before that. And in my entire life, I've never heard of a Jiffy knee, ever. I mean, it's just there is no textbook with Jiffy knee. And if you go to, so when we do, the way medicine is handled, and everyone handles things differently in their own line of work, but the way medicine is handled is that most of the studies are published in peer-reviewed journals, and the number one place to search for those journals is the National Library of Medicine. Okay, it's called PubMed. That's where all the sort of repository of medical information in the United States. And so if you go to PubMed, because I wanted to know when people kept asking me, what is a Jiffy knee? I was like, I don't know what a Jiffy knee is. And so I went and looked it up, and there's no articles, like zero. Okay? Now, if you look up subvastus knee replacement and you just put in these three words, about 6 months ago, you'll have 141 peer-reviewed articles. So I've watched the video that this surgeon, group of surgeons has. It appears they're just doing a subvastus knee replacement and calling it something else, and attempting to say like this is the only place in the United States where this can be done. It doesn't make a lot of sense, but I know a lot of patients don't understand that. And so they see it. And so from what I can tell, it's a subvastus knee replacement. But if you look in the peer-reviewed journals, There is nothing about this. There's no peer-reviewed studies on it. It's just a name that someone picked out. Let's see. So why should you think about choosing the SubV knee? I think here are the reasons that I think it could be a good option for patients. I think it's completely muscle and tendon sparing. I do think it's the most minimally invasive technique for total knee replacement, although knee replacement by its nature is invasive, okay? So by its nature is invasive, but I think this is potentially the most least invasive way of doing the surgery. I think it offers the following potential advantages we talked about: less pain, better strength, improved range of motion early on, and a quicker recovery, especially in the first 3 to 6 months. So what we want to do is get patients back to the life they want to live, doing things they want to do with their loved ones, and have them enjoy their life. So thank you for your time and attention. Well, fortunately, we're going to actually video this talk tonight, and we're going to put it up on the platforms you see there. So if anyone missed anything, you can go back and check it out, or other people can view it as well to learn. And at this point, I'll turn it over to you guys for questions, and we'll try to answer as many questions as we can. Yes?
There are some questions in the back about, a lot of you all couldn't hear the patient testimonials right here. So what he just said, on this sheet, on the YouTube part, it will be up tomorrow evening on YouTube. So if you all missed any of it, want to hear the YouTube one, you can go hear all of that tomorrow evening.
And actually, the patient testimonials, almost all of those are on YouTube, and they're in a longer format, some of them. So those are just snippets of it. So you could check it out on YouTube if you like, or some of them are on Facebook as well. Okay, questions? Yes, ma'am.
As far as BMI is concerned, still below 40 for Ortho Virginia?
Yes, so our goal is to get people's BMIs below 40. The reason being,
what was the question?
The question was to be a candidate for joint replacement. Do we, at Ortho Virginia, is our general rule and guidelines to get your BMI below 40. So your BMI is your body mass index. It's basically a ratio of height and weight is what it is. And so, yes, our goal is that. Do we have exceptions? Do we try to, sometimes allow for wiggle room? Yes. But the reason that we do that, so we generally don't want to operate on folks who have a BMI of 46 until they get that down, is that we know from the studies the risk of complications definitely goes way up. And for patients, they just know that their knee hurts or their hip hurts and they want it fixed. But things can be worse if you develop an infection or you have like a fracture, loosen the components. So our goal is to help people get to a point where they can have the best chance for success possible. So that's our goal there. But yes, is there some wiggle room? Yes, but generally we try to get BMIs to 40 or below for elective joint replacement. Yes, ma'am. Yep.
I had a sports injury in 1975. I've had 5 surgeries, the last one being a partial in 2010. The first 2 surgeries were full, regular cut on the inside of my leg for medial meniscus. I asked my last surgeon who did it in 2010 if he could go into that side scar. He did. And now I have a partial, and I saw that sometimes it may or may not be doable to do this if you've already got a partial. But he did not do the center cut thing.
Right.
He probably did similar to.
He might have done that. Or sometimes you can use the incision, and then once you get under the skin, you sort of mobilize over to another approach. But like if you needed additional surgery in the future, you would probably do a more traditional approach. After all those surgeries, you're going to have a lot of scar around that quad.
The other surgeries were arthroscopic.
Yep.
To clean out cartilage a little bit. The other thing is, do you use a custom-made device, or is it small, medium, large?
So yeah, it's the devices we use. So 99% of knee replacements in the United States are done with basically off-the-shelf components. So it's not just small, medium, large. They actually come in a lot of sizes, probably like 20 different sizes. There's one company called Conformis that did do custom components. They had some, in my experience, it wasn't the best outcomes. It's really decreased in popularity, especially in Virginia. But yeah, all the major companies, Zimmer Biomet, DePuy, Stryker, they're all off-the-shelf components with a lot of different size options. Yes, sir.
Can you speak to the various people I've talked to, and you, full disclosure, you did my hip, and it's great.
Okay, good. I'm glad.
But in talking to various people that have had their knees done, there seems to be a trend, at least among the people I've talked to, where they're getting robotic knee replacements. Can you speak to that?
Yeah, sure. So I was actually myself and Dave Miller were the first ones to do robotic surgery, or we call robotic surgery in Richmond. It was probably like 13 years ago, maybe. We had a Mako robot at Chippenham that we were using. So I've used the Mako robot. I've used the Rosa robot. I've been on the validation team. I've flown to Indiana to help validate the Rosa robot and see if it could do the things. And I've used those. The hospitals bought them. In my opinion, the robot doesn't help that. So when you think about, when people say robotic surgery, it's not the actual robot doing the surgery. With the robot, when we make those bony cuts, the robot is a navigating tool to basically allow you to make the cuts where you want to. You can also use mechanical alignment as well. In my experience, the reason that I stopped using the robot after trying it multiple times was that there are times when the robot was saying to do something that I just didn't think was going to be right, okay? And so my thought, to use the robot, you typically have, in most platforms, you have to put pins in the femur and the tibia, so it involves a little bit more invasiveness of the bone, per se. And I found that when the robot was telling me to do one thing and I felt like I needed to do something else, I can't really blame the robot if it's the wrong thing. So I was doing what I felt was the right thing. And I do think that the robot is only as good as the information you put in. And so if you're not going to trust it more than you trust yourself, then there's not a lot of reason to have it, because it's not less invasive. That's blatantly not true. The idea is that it could reduce errors in implant placement. That's the thing. Like, if you look at the marketing about it, it's like it's less invasive, you don't have to do this. That's not true. If you look in the orthopedic data, when we actually talk among surgeons, the question is, does it improve clinical outcomes? There's been multiple studies that say no. Does it reduce error rates, specifically among lower volume surgeons? The answer is yes. It does reduce error rates among lower volume surgeons. Does it have much effect in high volume surgeons? No, because those surgeons are typically pretty facile at getting the components where they want to go. So for all those reasons, I don't do it, but I have some partners that do, and I don't think there's anything wrong with it. And they may just trust the robot more than me and be more a believer in that technology. We'll go gentleman and then the lady behind. So, yes, sir.
Do you utilize a tourniquet in your surgery?
I don't. So when I first started, I did, but I stopped using a tourniquet for almost all knee replacements probably about 14 years ago. I do think it slows the surgery down a little bit because you have to deal with the bleeding. So first of all, does everyone know what the question is regarding tourniquets? So it's not really pertinent to hip replacement. You can't put a tourniquet on the hip. It's too high. But the knee, you can put basically a cuff around the leg that you inflate usually to about 250 or 300 millimeters of mercury pressure. And it basically strangles the leg of blood flow while you do the surgery. And the surgery, you may have the tourniquet up for an hour or so. So my concern is the muscle. So having damage to the muscle, think about it. It's pretty tight. Like a blood pressure cuff typically goes up to maybe 200, 220. Now imagine going up like another 50% and then holding it for an hour. It does put a lot of stress on the muscle. The other thing that I've noticed that I think is advantageous to not using a tourniquet is you're actually forced to deal with the bleeding while you're doing the surgery. If you have the tourniquet up, it's like, oh, this looks great. There's no blood anywhere. Just do the surgery, put everything in, close it up, let the tourniquet down, and then what happens? Boom. There's this huge bleeding thing. And so I think it actually helps patients get motion and stuff because we don't have as much bleeding at the end of the case. We deal with it during the case.
I had knee replacement 9 years ago, and my surgeon used a tourniquet. Is your opinion that can lead to nerve damage?
I have seen people mention that in studies, but that is not the most common concern with the tourniquet. I would say my more common the concern I would have more is just irritation to the muscle, and then the fact that you get this rebound bleeding when you let it down at the end, and potentially more bleeding after the surgery rather than dealing with it bleeding before. Yes, ma'am.
I heard that, let's say, like I have a torn ligament, and going through the SubV replacement, gonna take away this ligament. You don't need it anyway. So in my mind, I'm trying to picture when you have this knee replacement, what takes the place of the ligament that you already have torn? How do you create that stability?
Yeah, so you're talking about, so most people are talking about things like the anterior cruciate ligament or the posterior cruciate ligament, which are the two most common ones that would be affected. Some people might have a chronic ACL tear. So there's a couple things. So almost every knee replacement takes the ACL out if it's still intact. Most ACLs are not intact because the arthritis, it's just become degenerative by the time you get to knee replacement. But if the ACL is intact, you would take it out during a knee replacement. The question is, what replaces that stability? The answer is it's usually the geometry and the makeup of the implant. So the way that the plastic is shaped, it gives some inherent stability to the knee. The other answer to your question is that knee replacements are not made to play, running back for the Colts with. They're just not. So knee replacements are made to do things like play pickleball or go for a hike or walk or play tennis or golf. All of those things, great. So even with people that have ACL deficient knees, it's really those high impact activities that involve cutting and stuff where the ACL really becomes obvious that it's deficient. So with a knee replacement, the plastic does provide the inherent stability. And so I would say having instability due to cruciate ligament deficiency after a knee replacement is a very rare thing. We usually don't see that. Most people have pretty good stability. Yes, ma'am.
Sorry, I have one more question.
Sure.
Are there any knee conditions other than having previous surgery, BMI issue that would prevent you from doing a SubV?
Stiffness. Stiffness is the yeah. So stiffness. Let's see. Those are the main ones. Scar tissue from past surgery, stiffness. No, that shouldn't affect it all. No.
A little bit of a fracture in the knee is not going to.
No, not yeah. I mean, obviously, if you had a big fracture, we want to fix the fracture before doing the knee replacement. But yeah, so like insufficiency fractures and stuff, no, should have no effect. Yeah, I'm able to go here real quick.
Do you typically require or promote having physical therapy to prepare for the surgery?
So a lot of my patients, we do. It's patient specific. So there are a lot of patients that come in and they're like going to the gym, they're active, and they have pretty good range of motion of the knee. Their knee just hurts. And so in those patients, I'm not sure therapy is going to really do that much. But for people that are a little more deconditioned, maybe have stiffness, a little more trouble with mobility, absolutely. We send patients to pre-op therapy all the time. It's usually patient specific. Yes, sir. I'll go here and then here. How about that?
Okay.
Yeah.
I have 3 questions, but quick.
Sure.
Can you have a knee replacement with a spinal block instead of general anesthesia?
You can, but that would be done at the hospital. They don't do the spinal blocks at our surgery center, but yes, at the hospital you can.
Can you have both knees done at the same time?
You could. I don't do that because I don't think that it's the best thing for patients. But there are some surgeons that do both knees at the same time. It's not really what I would recommend.
And what kind of pain meds do you use after surgery?
After surgery, most people, the most common ones we use is a narcotic, oxycodone or Dilaudid are the 2 most common ones we use after surgery. And how much is used is really patient specific. Okay. Yes, sir.
Is there an alternative to titanium?
So knees are generally made up of 2 main metals, cobalt, chromium, and titanium. The titanium is probably the most hypoallergenic component. And they're actually, so are you allergic to titanium?
I can't have tooth implants or any of that.
Yeah. So if you're allergic to titanium, so most of the tibial components now, the femoral components are cobalt, chrome. The tibial components typically are titanium, although there still are some that are cobalt chrome. You'd have to check on that. So you could probably find a cobalt chrome one. Generally, when people have metal allergies, though, what I do is refer them to an allergist to have actually objective testing to see what they're actually allergic to. Because we don't want to make decisions and choose potentially implants that might not be the best or things that are typically not used because of a supposed allergy.
It's a hard one.
Right. Yeah, you'd probably go to an allergist and try to document what you're actually allergic to.
Yeah, I've done that with the periodontist.
Yeah. Okay. Good. Yeah. Yes. Oh, you're welcome. In the back.
Do you have studies that show that it is extremely helpful to continue at home PT after, months afterwards? Does it help when you have had a knee replacement ongoing?
So I don't know if there's necessarily studies that look at prolonged PT activity, but I can tell you sort of anecdotally from my practice, I think that people continuing with their general exercises, promoting range of motion and strength, is going to do nothing but help. I don't see any negative to that. And so I generally do ask patients once they finish therapy to still get out, walk, be active, work on their knee range of motion. It's not that they have to do an hour of exercise every day, but maintaining that mobility and that strength is, I think, can only help you long term. Yes, sir.
How long does a knee replacement last? And if you've been active, jog and all that, before knee replacement, can you do that at some point again?
Yeah. So those are both really good questions. How long does a knee replacement last? And sort of what can you do after knee replacement? Can you jog and things? So to your first question, I think there's good data that knee replacements we're putting in now, we could have the expectation they could last 20 or 30 years or more. If you look at, like in my own practice, I've been doing this for about 18 years now. I can't think of any. I've had a couple people who've worn their poly, the plastic, and I've had to go in and just replace the plastic part. But I haven't had any knees just grossly fail just due to plastic wear and we call lysis of the bone, where the bone starts to resorb. So I think 20 to 30 years or more is a reasonable expectation. As far as jogging, we say that we generally recommend with knee replacement to try to avoid repetitive impact activities just because it can wear the implant. That being said, I have a ton of patients that still jog and do activities like that. People, like I said, playing pickleball, tennis, obviously are moving quickly in those sports. I generally encourage people, if they were a long-distance runner before, to think about cross-training to other activities like cycling or elliptical, things like that, and mixing in some running with it. But the overall answer to your question is that we still do have patients that jog after knee replacement. Yes, ma'am.
Could people get allergic reaction to the metal components? Is there metal components?
Yes, and there are metal components. It is possible. Usually I ask my patients if they have any known allergies. If they don't, we just go forward. The risk of rejection from metal allergy is very rare. So in my entire career, I've taken out 0 knees from metal allergy. So it is incredibly rare. But I usually ask, and if people have a known allergy, we'll try to use a substitute. And if it looks like it's going to cause a problem, we'll send them to an allergist to have allergy testing done. But it is rare to have rejection of a knee replacement due to allergy. Yes, ma'am.
First, if they're various sizes, I'm assuming that you would put in the next size up rather than try to squeeze it into a smaller. But then how do you fill the gaps?
Well, the sizing choice is really based on a lot of things: bone quality, how tight or loose the knee is in flexion extension. There's a lot of things that go into that. That being said, in the system I use the Zimmer Biomet Persona knee system. There's probably 12 different sizes that each come in a narrow and a wide. So we're dealing with probably in excess of 20 sizes. And so unless you come in, if a person comes in and they're, say, 4'8", then we need to think about getting the micro sizes in. If the person's, 6'10", then we need to think about the macro sizes. But I think for anyone in this room, we're going to have a size for you, off the shelf that would fit pretty well. Ortho Virginia does, yes, at this point take Medicare, yes.
Last question. How critical is age to
the success? I mean, I've had people with significant success well into their 80s and even their early 90s. But in general, the older you are, it does take a little longer to recover, right? That makes sense. And the older you are, the risk probably do go up some. I don't think it's prohibitive, but they do go up some. And did you have a question, right?
I understand that if one leg is longer than the other, you before or after the surgery that can cause hip problems. How do you prevent that from happening?
So significant leg length differences, you see that more commonly after hip replacement because you can really stretch the hip out more and lengthen more. So you can, with the knee, if you try to lengthen significantly, what will happen is the knee won't straighten out because those ligaments on the side that we're leaving intact, they're just too tight. So you do see leg length differences after knee replacement. Typically, when a patient has both knees that are arthritic and you fix one and straighten it, so the knee was bent and now it's straighter and so it's functionally longer, that can be a problem. Usually it's not significant. Most people, it's not something that causes problems in other joints and stuff like that. If it was bothering them, they would use like a little shoe lift in their shoe or something of that nature. And a lot of times they would just elect to get the other knee fixed eventually. Yes, that was a question. Yes, ma'am.
Yeah, if you're 88 years old and you have bone-on-bone with medical problems, would you do that type of surgery, or would you recommend just at 88, just get cortisone shots?
So with our patients that are in their late 80s, typically I tell them if we can manage this non-operatively, I think we should give it a shot, right? Give it a chance. But I have had patients who have been in that age group where the injections aren't working and the pain is just really debilitating and lifestyle limiting. And we go forward with surgery, and I think those patients have a good chance of having a great outcome. I'll talk to them about the risk, but we would try the non-operative things. But if it wasn't working, we would consider surgery. I don't think the age itself would be prohibitive. I've operated on one of my partner's mother-in-law who was she was in her early 90s, and her hip was just killing her. And so she tried all the non-operative things, and she's done great. She's done really well. So I think it's a patient-to-patient decision. Yes, sir?
My understanding is after traditional knee replacement, it's recommended that you sleep on your back for a very protracted amount of time. Is that the case with SubV?
Yeah, I mean that may be sort of that may be sort of a legend type of recommendation. I tell patients I don't care how they sleep. They can sleep however they want. They can sleep on their stomach. They can sleep on their back. They can sleep on their side. With hip replacement, sometimes you want to make sure your legs don't really cross way over at first. But even there, I really don't give patients a lot of instruction. I just tell them to sleep how they're comfortable. So I think with SubV or traditional, I would tell you sleep how you're comfortable.
My last question, if I may.
Yeah, sure.
Does your office do the gel injections?
We do. Yep. Yeah, Durolane, Synvisc, all that stuff. Yeah, we did those. Yeah. Yes, sir.
Do you suggest that your post-surgery patients take amoxicillin before every dental procedure, including cleaning?
So like I said, I've been doing this 18 years. I've never given anyone antibiotics for the dentist, to take routinely. There was a paper that came out when I was first starting, because that was typically done by a lot of surgeons, that showed no difference. If you think about it, if you go to the dentist to have a cleaning, right, and they clean your teeth, they floss your teeth, they look around or do whatever they do, I mean, how is that any different than flossing your own teeth at night? I mean, and if the idea is that if you stir up any blood in the mouth, you have to have antibiotics, by that logic, every time you bite your tongue or you bust your lip, you need to go immediately taking antibiotics, right? Those are larger lesions than you get from the dentist. So is there the potential of having like an abscessed tooth, the blood, getting bacteria in the blood and having it get stuck in the knee? Yes, but that's not routine cleanings or routine dental work. If you have an abscessed tooth, just like if you have an abscess on a heart valve or you have an abscess or infection in your foot, it could go to your prosthetic joint. But that's a lot different question than just saying every time I go to the dentist and I have like a small cavity that needs to be filled or they need to put a new crown on my tooth, I need to take antibiotics. That to me doesn't make a lot of sense. So I don't do that in my practice. I would say that some surgeons still do, but I really haven't had any problems, and we have a lot of patients out there now. So, yes, sir.
Any complications having a knee replacement on the same side as a hip replacement?
No, I've not. I don't think that's a big concern. Obviously, if they were being done close together during the knee replacement, you want to make sure you don't maybe aggressively manipulate. But even then, you're not going to be putting the hip in any unstable positions. So I don't really have any concerns about that. I've done a hip, and then typically if patients have arthritis on the same side, say right hip arthritis, right knee, typically you do the hip first because it's easier to do the knee rehab once the hip is fixed. If the hip's too stiff, you can't bend your knee. So you do the hip first. And I've come back within 6 to 8 weeks and done the knee, and people have done fine. So, yes, sir.
With such a large volume, you have such a massive case study possibility, but that would involve tracking people over time. Is your only source of input is feedback from people that comes organically?
So I mean, so you're asking, do we have? So we do collect patient data at Ortho Virginia through things like surveys and stuff like that. So we do have data on patients as far as their reported recovery. But it is correct that if, in an ideal world, we bring everyone back every year, do measurements, get data, take x-rays. But the question is that feasible for us? It's just not feasible for us to do. At some academic centers, they might do it in a subset of patients. But following thousands of patients on a yearly basis or even a 5-year basis is just a massive undertaking. That would be a job in and of my other job. So we just can't do that. So we do have patient-reported data, usually patient-reported like how you're doing, how far you're walking, stuff like that gets reported through surveys we send out. And we have our data in the charts, but in an ideal world, that'd be great to do. It's just a matter of having the time and the resources to do that. Yep.
Can you do a SubV bow-legged person?
On what now? A person with bow. Oh yeah, absolutely.
And then straighten it out afterwards?
Oh yeah, for sure. Yeah, for sure. So maybe one more question, and then we'll wrap up. Yep. So the main reason I don't is I just don't think people do as well. I think it's easier to focus on one knee at a time, recover, and then you could come back within 6 to 8 weeks once you get, recover from the blood loss, and do the other knee. Decrease risk of things like blood transfusions. I think able to focus more on that knee with therapy. Decrease risk of just other complications overall related to so much surgery. So that's my reason. So with that, we're going to wrap up. I'm happy to say hi or answer questions for anyone. If you have anything specific you'd like to ask, here at Ortho Virginia, we really try to do our best taking care of patients and getting them back to the things they want to do. I'm here. I have a lot of partners who are also great joint replacement surgeons. We also take care of all types of problems, spine, foot and ankle, hand. So if there's any way we can help you here at Ortho Virginia, please reach out, and we're happy to do so. So thank you for coming.